Okay, we should be live.
Thank you and good morning. We are the Senate Budget and Taxation Committee Subcommittee on Health and Human Services. Today is February 4th, 2022, and it's Wear Red Day for women. We are wearing red today to acknowledge the importance of cardiovascular or heart health. And so I just wanted to acknowledge that as we get started. We have 3 budget hearings today, and we are going to begin with the Department of Disabilities. We will follow with the Maryland Institute Emergency Medical Services Systems, and then we will conclude with the Maryland Department of Health Professional Boards and Commissions. So thank you all for joining us. Let's go ahead and turn to our budget analyst, Grace Patterson, for the presentation on the Department of Disabilities. Good morning, Ms. Patterson.
Thank you, Madam Chair. It's my pleasure to present the Department of Disabilities Fiscal 2023 budget analysis. We'll go to the first exhibit. The budget increase is 7%, and this is mostly driven by increased special funded expenditures, namely for assistive technology services and through the Telecommunications Access of Maryland program. Looking at the overview of how the agency will spend its allowance, the Telecommunications Access of Maryland program makes up over 37%, and then personnel makes up almost another third. Various other services for individuals with disabilities comprise the remainder. Looking at the change in spending from fiscal 22 to 23, the largest fluctuations are in personnel. The agency receives almost 2 new contractual positions, and those will mainly support assistive technology services. In addition, there's funding increases for housing programs, as well as assistive technology programs and services, and expenditures on the senior call check program, which the agency partially funds, in addition to funding from that's budgeted in the Department of Aging. Those expenditures for that service is expected to decrease in the allowance. Looking at personnel, I mentioned this earlier, almost 2 contractuals, 1.99 are added in the allowance, and those support the Telecommunications Access of Maryland program and the Assistive Technology Loan Program. There's a reduction, sorry, and there's a net increase of 1.99, but there's a small reduction to the Assistive Technology Loan Program. Going to the first issue, I mentioned the Telecommunications Access to Maryland program. So a primary function of this program is to provide accessible telephone service to individuals that may have a difficulty using telephone. These services are called Maryland Relay Services, but the program also provides assistive equipment to individuals with disabilities. So prior to fiscal 21, this funding supporting that program was budgeted in the Department of Information Technology. The Telecommunications Access to Maryland program is funded with the Universal Services Trust Fund, and revenue to the fund is from a telecommunications subscriber surcharge. So it's a 5-cent charge on like telephone bills or cell phone bills. And going forward, revenue is expected to remain relatively level, but after the trust fund was transferred to the Department of Disabilities, and the department began offering more services and also began funding the new senior call check service through the Universal Services Trust Fund. Expenditures increased starting in fiscal 21 and going forward into 22 and 23. And the department projects that if expenditures remain level at fiscal 23 levels, that the fund balance that came over from DO-IT at the time, it was in excess of 12 million, will be spent down by fiscal 26 and could even incur a deficit that year if either expenditures aren't aligned with revenues or if revenues don't increase. So DLS is recommending to request a report on Spending from the fund, as it reflects a relatively substantial change from prior years, and how it plans to address any potential revenue shortfall in the out years. Going to the second issue, this is a new program the department created in calendar 2020, the Maryland Assistive Technology Reuse Center. And the Reuse Center accepts donations of assistive technology and refurbishes the equipment and redistributes it to the public. So as of November, the value of all equipment collected was less than $200,000, and estimates for expenditures specific to the reuse center weren't available. So DLS is asking the agency to comment on expenditures for this program to ensure that this service model is the most cost-effective means to distribute assistive technology to folks. And then going to the third issue, this is an update on the statewide IT accessibility initiative. The department continues to develop and lead training of the state employees and individuals involved in IT throughout the state. And in the upcoming fiscal year, the department plans to lead a statewide review of websites and to hopefully create a baseline for comparison of the accessibility of the state's online presence. So in future years, it could be measured how accessible the state's online presence is. I mentioned earlier this recommendation for a report on expenditures from the Universal Services Trust Fund. That concludes my presentation. I'd be happy to take any questions.
Hey, thank you very much for that analysis. Are there any questions from the subcommittee for Ms. Patterson? Okay, I don't see any hands raised, so we will turn to the Honorable Carol Beatty, our Secretary for Department of Disabilities. Good morning.
Good morning, Madam Chair. Thank you for having us here today. And thank you to the members of the subcommittee. I am Carol Beatty. I am the Secretary of the Department of Disabilities. And with me here today, I have Deputy Secretary Christian Mealy and Deputy Assistant Secretary John Brennan. And we also have some of our directors here who will be available for questions. We want to thank Ms. Patterson, and she's done a wonderful job as usual, and we appreciate her diligence and her thorough analysis. And you have our written testimony, so with your permission, I will discuss the issues that were raised by the analysts and in the report.
Thank you.
All right, so. So we were asked to comment on our coordination with the Department of Aging and overseeing the Senior Call Check Program, its FY23 allowance decrease in funding, and the relationship that this all has to the USTF fund balance. So a little bit of background, the Senior Call Check Program was established by legislation in 2019. It's managed by the Department of Aging per the legislation, and we have really no authority over this program. The funding for the program does come from the Universal Services Trust Fund, which is also known as USTF. And as pointed out in Ms. Patterson's analysis, the fund derives its revenue from a monthly fee to customers for telephone services. It was originally created to fund alternative communication access services for people who are deaf, hard of hearing, or who have other communication disabilities. The USTF fund currently financially supports programs under our department, including the Telecommunication Access of Maryland program, which includes Maryland Relay, the Maryland Accessible Technology Program, and the Deaf-Blind Communication Facilitator. It also funds the recently established Senior Call Check Program, which we've just talked about. MDOD coordinates with Aging to include the Senior Call Check Program costs in our budget request. The USTF currently has a surplus, as was noted by Ms. Patterson, and that surplus is declining because of rising costs, evolving customer needs, constantly changing technology, and the addition of new programs, such as the Deafblind Communication Facilitator and the Senior Call Check Program. MBOD has the responsibility for monitoring this fund, and we're charged with communicating with the Public Service Commission regarding the cost of the services funded through the USTF. Since assuming responsibility for TAM and Maryland Relay and their USTF funding source in the summer of 2020, MDOD has completed projections based on historical information, anticipated increases in contractual costs, and growth forecasts. All of the services funded by the USTF are legislatively mandated services. We've seen fluctuating expenditures due to these contract changes, growth, and the recent addition of programs. And this has made projecting the USTF future status difficult. However, we anticipate a clearer picture this year based on actual experience and firm contractual agreements in this particular coming calendar year. The Senior Call Check FY23 request was based on their anticipated needs for the year, and it was not reflective of substantive programmatic changes. The funds requested will continue to pay for the call center, outreach and marketing, and administrative costs. MDOD plans to work with aging to create a plan to address the USTF revenue shortfalls and submit with our FY24 budget request. It was also recommended that MDOD submit a report regarding its progress implementing planned programmatic changes, data indicating utilization of TAM services, and updated projections of USTF funds. And we concur with this recommendation, and as previously mentioned, we'll coordinate with the Department of Aging to prepare the report and submit it with our FY24 budget request. And then it was also requested that we provide an estimate of the Maryland Assisted Technology Reuse Center expenditures in FY22 and 23. And the department provides, so just a little background on that, the Department of Disabilities provides the state's assisted technology activities, which are funded through the federal AT Act. The Maryland Technology Assistance Program, or Maryland or MDTAP, operates the newly established MATER, we call this program MATER, program, which receives donations of gently used high-tech assistive technology devices. And those are things like eye gaze systems, video magnifiers, and communication devices. This unique program is located at the Howard County Loan Closet, and we are very thankful for the collaboration with Howard County government. From this central location, we are able to serve clientele all over the state. Our staff coordinates the repair, refurbishing, cleaning, and clearing of all the items before donating them to customers who request them. This work is accomplished by building relationships with the private sector, including working with community partners such as the Howard Community College and Volunteers for Medical Engineering. This innovative program is one of only a few dedicated high-tech AT reuse programs in the country. Program operation does not involve any state funds and helps Maryland TAP to satisfy the core requirements that they have under the federal AT Act. Equipment reuse is one of 4 mandated state-level activities required of the federal funding. For the MATER program, the federal funds support the salary of one part-time staff person who works approximately 16 hours a week on site, and her work includes facilitating the donations, one-on-one client consultation, and equipment training. The projected federal fund salary costs for this position for FY22 and 23 is approximately $32,000 per annum. There are no other estimated state or federal fund expenditures. So in conclusion, we concur with the recommended operating budget recommended action to adopt the recommended narrative regarding expenditures and projected balance of the USTF fund, and will coordinate with the Department of Aging to author the report by the due date. I want to thank you again, and we'll be glad to answer any questions that the subcommittee members might have.
Thank you very much, Madam Secretary. Are there any questions from the subcommittee for the secretary or her team? Senator Eckert.
Thank you very much. Thank you, Madam Secretary, for your very thorough presentation and for our staff who presented as well. I do have one question. Secretary Kramer has an equipment reuse program as well. Do these two programs work together, or are they two different programs, and are they two different types of equipment?
That's a wonderful question, Senator Eckert. Thank you for asking. Yes, we do work together. In fact, when the Department of Aging began planning for their durable medical equipment reuse program, our department was very much involved in assisting and providing technical assistance, because again, part of the AT Act requirements is reuse, and that can include medical equipment, durable medical equipment, but in our case also includes high-tech assistive technology. Right. So we were involved at the very beginning in providing support. They have recently opened, which is wonderful, and we refer clients to them for durable medical equipment, and they refer clients to us for the higher tech assistive technology. So it is a very collaborative relationship.
Great, thank you very much. Thank you, Madam Chair, that was helpful.
Thank you. I had the same question, so I'm glad you pointed that out, Senator Eckert. Okay, are there any other questions for the department? Okay, seeing none, we do have a few members of the public that have signed up to testify, so we will turn to Anna Lewis.
Yes, good morning.
Good morning. I hope I pronounced your name correctly.
Anil, but that's fine.
Anil, please forgive me.
Forgive me for not being able to turn my video on. I had some technology problems. I want to thank the chairwoman and the members of the committee for this opportunity to speak on behalf of the non-visual accessibility initiative grant that has been included in the government's budget for so many years now. I submitted written testimony, so I won't go into all of that detail, but I did want to just focus on the fact that the state of Maryland is blessed to have Secretary Beatty and her very competent staff. I don't know whether you guys realize it or not, but the MDOD relationship within the infrastructure of the state government with direct access to the governor is exemplary nationwide. I think that we could spend all day talking about the economies of scale that are gained by the fact that Secretary Beatty and her staff are able to interact in a way with all of the various departments to make sure that the concerns of people with disabilities are dealt with and addressed very early on in the development stage of most policy and implementation and acquisition of equipment. I just really am pleased that the National Federation of the Blind, most transformative organization of blind people in the country, was able to partner in a way that makes this public-private partnership, again, exemplary. The work that we do every day as a nonprofit to create opportunities for blind people to live the lives they want complements and leverages the grant funding through the budget in a way that Maryland benefits, we as an organization benefit, but overall citizens of Maryland with disabilities benefit in a very expeditious, efficient, and economic manner. So I could point out some areas to demonstrate that, but again, in the sake of time, I will yield unless there are any questions for me.
Colleagues, are there any questions for Mr. Lewis? Let me thank you so much for your testimony, and it is wonderful to get positive feedback and hear about things working well. So thank you so much for your testimony.
My pleasure. Thank you.
All right, colleagues, we have Amanda Lay and Rachel London also signed up to testify. So if they're here, you can proceed in that order.
Good morning, Madam Chair. I'm Rachel London. I'm actually the Executive Director of the Maryland Developmental Disabilities Council. We are a program of the department, so I was just here to answer questions.
Oh, very good. Okay.
Thank you.
Thank you very much. So you came strong, Madam Secretary, with a good team this morning. I don't see any questions from the subcommittee. Okay, seeing none, that will conclude the hearing on the Department of Disabilities. Thank you to the analyst and to those who shared remarks this morning. Colleagues, will now turn to our next budget, which is the Maryland Institute Emergency Medical Services System. Our analyst is Mr. Andrew Garrison. Welcome back.
Thank you, Madam Chair. Good to be back in front of the subcommittee this morning. Members of the subcommittee should be seeing the budget for the Maryland Institute for Emergency Medical Services System, or MIMS is what I'm going to be saying for short throughout the next couple of minutes here. First, looking at the overall budget, what we see is that purple bar. Those are the reimbursable funds in this budget, and that's really where all the increases that we're accounting for. And these are actually programs that are currently underway and being finalized with the MOU. So eventually we're expecting to actually see some fiscal 22 dollars brought in for that as well. Most of these dollars are going to be coming in from the health department. And it's really to one of the programs that we're expecting to be coming in is the Critical Care Coordination Center, or C4, that we talk about throughout here. And those funds are going to be coming in from the health department. And what that program is doing is trying to have a center that's staffed 24/7 that can help coordinate some of these critical care resources throughout the state with different medical practitioners on call as well as needed. This is something that was actually started during one of the initial waves of the pandemic. But so far, MIMS actually reported that a lot of the use has been even non-COVID related needs. And so that is why they're hoping to continue it into 23, and that's being reflected in the budget as well. And then additionally, we have a new stipend program, an education stipend for EMT providers that we'll be going a bit more in depth to, but that's really what's driving that change here. Otherwise, just to give a quick snapshot of the agency expenditures, we have a little bit less than half of the total agency budget going towards personnel, including regular state employees as well as contractual staff, some of those folks who are on contracts for particular federal programs. And then we have, programming that MIMS is doing on behalf of other state agencies coming in as reimbursable funds or in conjunction with other state agencies, and then some federal funding as well. In particular, MIMS is part of a national capital regional emergency response system. So that's where some of those federal dollars come in from. And then, of course, a large part of MIMS's budget is also around IT and telecommunications, because this is an agency that does a lot of that coordination for the emergency medical services. So there is a pretty sizable chunk, about 15% of the budget, that's related to that. Some of MIMS in particular over these last, I suppose almost 2 years now, has been really involved in the state's response to COVID, and in particular looking to staff up some of the workforce and then coordinate those services throughout the state. So one of the more recent responses that we have here is some regulatory actions to really expand either the scope of practice for emergency medical technicians, or to get more of those types of providers into the state and to be able to do some assistance there. I go through a brief list of some of the very recent regulatory actions that were in response to the governor's most recent executive order on January 4th in response to some of that Omicron wave. And then the other item that I mentioned at the top that they've done in relation to the pandemic response, and again, kind of looking at the EMT workforce, is this education stipend. I've outlined the planned stipend amounts here in front of you for Exhibit 3. But this is, again, something that is new in this budget in 23, but we would expect a little bit of funds to come in later down the line for fiscal 22. And given the role that MIMS has played throughout this, and of course the role that EMT providers themselves have had in the state's response to the pandemic, we do have a recommendation here for committee narrative to submit a report about how these different initiatives have impacted the EMT staffing shortage to the extent that it's existing, and what these interventions have done to increase the state's EMS workforce. And so that's in front of you here. The other item that we usually talk about in this budget is on Exhibit 4, and that's emergency department wait times. We get this data from the federal government, CMS, the Centers for Medicare and Medicaid Services. And what they look at is emergency department wait times. We're showing that in front of you in minutes today for the period of 2020. And we're comparing Maryland, which is our first bar, to both the national average with this red line across the screen there for you, as well as some of our neighboring jurisdictions. Washington, D.C. is also really high, but actually I do note in the analysis that Maryland's one of the highest states, period, with of course D.C. obviously being not a state. And so this is something that even when we look at the individual hospitals in Maryland, it's not one or two outliers really driving it. Many of the state's hospitals and emergency departments are well above this national average. And that is something that we highlight as it does kind of interact with the state's emergency response and EMT system. Ultimately, the only recommendation that DLS is making in this budget is that narrative around EMT shortages and how some of those interventions have helped address those shortages. And what we're actually doing is asking that it be submitted as part of the annual report that MIMS does and not part of a separate submission under this recommendation. But that does conclude my presentation, and I'd be happy to take any questions.
Thank you very much. Are there questions from the subcommittee?
Thank you, Andrew.
Okay, I don't see any questions for the subcommittee. Andrew, Mr. Garrison had a question on your chart on page, I guess it's both Exhibit 4 and Appendix 2 regarding the hospital wait times. I know you mentioned these are national reports. Do we have any sense, are we capturing, how much a problem non-emergent use of emergency room or care that could be diverted to other types of providers?
So thank you for the question, Senator. I'd say broadly speaking that at least from the federal reporting that we get, that's not necessarily something that's been considered. I do know that the federal government has revamped some of these reporting measures recently. We used to be looking at a couple different emergency department measures, and this is really the one that's maintained over the last 5 or 6 reporting years. I do know there was a report a couple of years back from the hospital association that looked particularly at delays that may be occurring from inability of getting folks into maybe inpatient psychiatric beds in particular, and those overstaying happening on the ED side of things. But given the, I would say, widespread of this, I don't know if there's necessarily one exact item that could be causing all these delays across the state. MIMS, I think, might be able to comment specifically on some of the other more recent trends they're seeing. And of course, too, obviously, it's been a interesting couple of years to look at hospital data, given the challenges that hospitals have been facing and some of the irregularities that we've seen really across the healthcare setting.
No, thank you. That makes a lot of sense. Having worked in primary and preventive care, I was just curious if an investment there might help us with some of that statewide. It seems like clearly we've got an issue. So thank you for that. I see Senator Young has a question.
Yes, those wait times are kind of scary. Do they do a breakdown on the type of emergencies? For example, if someone comes in bleeding or someone comes in with chest pains for a heart attack, do they do a breakdown in terms of how fast they get them in versus someone who probably doesn't have a doctor and just comes in to sit there because they have no place else to go?
On the specifics of the federal data, we don't necessarily have that. They're really aggregating the ED numbers that are being reported. I do know that MIMS has part of their kind of care coordination system and having a level of severity. And so if there is certain, and they should certainly be able to expand on this more, but if a particular emergency department is especially backed up and a provider is able to bring them to 1 or 2 locations, they will try to bring them to somewhere that has less of a wait time in that exact moment. And there is some tracking and coordination that happens around that. But specifically, at least on the federal data side of this, we don't have wait times for actual emergent medical uses versus, some of the kind of folks who are walking into our EDs.
Yeah, I think I can't deal with the national situation, but it would be important to know in terms of Maryland, because it's where we have some say. I had chest pains in an arm ache once and called my doctor, and he said, go straight to the emergency room. Turned out to be nothing, but I walked into the emergency room and told them what it was, and they took me immediately. And it would be nice to know if the hospitals are dealing with things like that. And like I said, someone that walks in and is actively bleeding, if they're prioritizing and taking them, and like I said, letting the person sit that just came there because they didn't know where else to go. Because otherwise those times are scary if someone's there seriously sitting for 2 hours.
Yeah, thank you.
Thanks.
That may be a triage question that we can ask the department when they come up. That's a very good point. Senator, was that your final question, Senator Young? Oh, okay, thank you. We'll turn to Senator Roosevelt.
Thank you.
Oh, come on.
On the same topic, can we go back to the chart?
Sure. The appendix or the exhibit?
I don't know what's an appendix. It's the wait time. Okay.
Sure.
What is the source of this information? It says CMS. So how recent is this data?
Yeah.
So this is a period in 2020. We have the CMS reports that and actually this particular set that they reported in 2020 is only that second quarter, or the second 2 quarters rather, the back half, because of some of the obviously difficulties in reporting and the irregularities that early phase of the pandemic really caused in different hospital settings.
I'm sorry. So this is the second 2 quarters of calendar 2020.
Yes.
So this was in the middle of COVID.
Yes. Yeah.
So have we gotten similar data over the years? Do we have trend data?
Yes. So, and I mentioned this a bit earlier, the CMS has kind of revamped some of these wait time measures. This particular measure that we look at has been consistent throughout, and Maryland is consistently one of the higher wait time states, even prior to COVID. It is something that we routinely point to in this analysis as a challenge that Maryland hospitals and ED settings face.
And has there been any initiative by the health department or by the legislature or by anybody to try to figure out what the problem is?
There has been, I would say as recently as 2 years ago, certain community narrative or JCR reporting on hospital wait times in terms of specific initiatives that happened at the hospital level or system-wide. I think MIMS might be able to better answer what they're doing to address some of this, but it is something that, I think has been a trend in the state, certainly.
Right, but I meant more at the macro level. We have a 50% bigger wait time than average. I mean, that's very material. And if it's going on year after year, it's a big deal where I would presume somebody would be looking at it comparing to why are almost all the other states so much better. I mean, is there any data that DLS has compiled over the years explaining why other states are so much better?
I'm certainly not explaining why other states are better now. To the extent that we've compiled data, it's been looking at what the federal government's doing. We're certainly limited in our ability to look at the macro wait times relative to CMS.
And CMS doesn't do any analysis nationally on this. They just do data.
It's part of their broader quality measure reporting that they do.
But they don't do analysis. That's my question.
Not to my knowledge, no.
Okay. All right. Thank you. Thank you, Madam Chair.
Thank you, Mr. Vice Chair. All right, Senator Eckert has a question.
Thank you very much. Just leave that chart right on up there. My questions regarding that chart as well, if you don't mind. The one with all of the hospital wait times, Andrew. Thank you.
Yeah.
I was looking on there and it was interesting because Atlantic General has the least and they have a big poster and they hail quick response in the ER, which is a good thing. But then if you move down, you'll see Upper Shore Chestertown, you'll see Upper Shore Easton, and there is another one, Upper Shore, but I don't see unless my eyes are missing it. George.
They're towards the end here, Senator.
Yeah, is that Dorchester? You know what Upper Shore is?
I don't know offhand where that one's located.
Okay, because we have a hospital in Dorchester County that's just converted to an FMF. And that's why I was curious how that fits, or do FMFs now not fit in that, because it opened this past summer, but that was in 21, not in 20. So the data would be collected. I'm just curious because Upper Shore is pretty high, and that would concern me locally. And then I have some other questions for MIMS regarding behavioral crisis and the emergency room as well when we get there. Thank you.
Of course.
Thank you, Senator. Are there any other questions for Mr. Garrison? Okay, seeing none, we will turn to MIMS, and we have, or MEMS, depending on how you pronounce it. We have Dr. Theodore Delbridge, who's the executive director, and we say good morning, and feel free to introduce any members of your team that you have with you in your response.
Good morning. Thank you very much for the opportunity to be here. And I'll try to elaborate on some of the things that Mr. Garrison talked about. And I've been preparing for the questions that you're going to blast at me here toward the end. On the board somewhere is Jeannie Abramson. She's our Chief Administrative Officer. And if I say something stupid, I'm sure she'll jump in and correct me. It's MEMS, is how we say it. MEMS is the Maryland Institute for Emergency Medical Services Systems. And as you know, we're an independent state agency responsible for coordinating the statewide EMS system. And we do that by promulgating clinical protocols and providing medical direction, operating the statewide EMS communication system, licensing and certifying EMS clinicians, emergency medical technicians and paramedics, supporting EMS educational programs, and licensing commercial ambulance services. Thanks to Mr. Garrison for his comprehensive analysis with which we concur, and also to Rebecca Bazzari, our DBM budget analyst, who's very helpful over the course of the year. Much of what we've been focused on for the past year has been our ongoing efforts to respond to the COVID-19 pandemic, ensuring as best we can that the EMS system has the necessary resources to respond and is doing so to the best of its capabilities. As you know, the governor issued a declaration of health emergency in March 2019 and subsequent executive orders that provided the MEMS executive director, me, and the EMS board with some latitude in augmenting the EMS workforce. And in all subsequent to that, we issued 9 public notices that carried out that work and went through most of 2020. Those things included creating a category of provisional EMS clinician. They were people who were students who couldn't complete their course of study because of lack of resources in the educational system or the ability to test at the end. There were people who were expired and we recruited back into the workforce. And there were people who were certified or licensed in other states who we expedited reciprocity for. And in all, we recruited more than 1,200 of those people into the EMS system. And since then have created a regulatory path for them to become permanently certified or licensed people, and the majority of them have done so. We loosened the requirements for commercial ambulance service drivers so that ambulances that were transporting basic life support patients could use drivers who weren't as medically qualified as they had been, and have worked with the Public Service Commission to license them appropriately and do the necessary background checks and things like that. And we recruited or enabled EMS clinicians, EMTs, and paramedics to be vaccinators of the public. Previously, statute restricted them to vaccinating other public safety people, and we managed to broaden that. In all, EMTs and paramedics vaccinated more than 80,000 members of the public and more than 20,000 members of their own brethren, public safety workers and government workers in efforts to maintain the continuity of public safety and government. Last year, a bill was passed that enabled paramedics to continue to provide COVID-19 and influenza vaccines to the public through January of 2023, or up to January 1st, 2023. This year, House Bill 286 seeks to extend that sunset to 2026. And I'll be happy to answer any questions you have about that when the time comes. As Mr. Garrison mentioned, we stood up the C4, the Critical Care Coordination Center. This was our effort to ensure that patients who needed critical care resources had access to them throughout the state. Since December of 2020, We've been running continuously. We do so with a paramedic coordinator and an on-call intensivist or critical care physician specialist. We fielded more than 2,600 calls from Maryland hospitals to facilitate access for critical care needing patients who were in emergency departments to wherever that care might be available. We are one of 4 or 5 similar systems in the country. We were among the first and have become a model for this kind of work. As was pointed out, Maryland emergency departments have been for quite some time, long time, and continue to be stressed by overcrowding that often affects the EMS system's ability to deliver patients to them. We've done a couple of things in that regard. We implemented this year a directed triage protocol. It's our effort to help EMS clinicians identify patients who shouldn't necessarily jump to the front of the line by virtue of their arrival at the emergency department by an ambulance. Some of the ambulance traffic to an emergency department represents actually a minority of emergency department cases. The majority of people walk in, and some of them might be sick or hurt beyond what is coming by an ambulance. And so we want to fit our patients in with the queue of patients who already exist. It's very disruptive otherwise. And so we've tried to get hospitals to adopt to that, and they've done a great job. We implemented what we call AHA, the At-Hospital Ambulance Dashboard. Our computer gurus, our IT folks here at MEMS, have developed a progressive web application that enables EMS clinicians to look on their phone or on a tablet computer and see what number of ambulances are at what emergency departments attempting to deliver patients to there. They know how many ambulances are there and how long they've been there, so that they may have a better informed discussion with their patients about where is the most appropriate place to go. And we continue to work with CRISP, the Chesapeake Regional Information System for our patients, to develop a near real-time monitoring system for all the emergency departments in the state so that we would know relative to an emergency department's capacity to manage patients, how many patients are there at any given time. And we're in a data validation phase of that. And finally, EMTs, as it was alluded to, are the backbone of the system. They represent the majority of EMS clinicians in the state, and they represent the pool of people who will go on to become paramedics in many cases. The rigors of training are often an impediment to recruiting new people. It's not an insignificant amount of time and energy and smarts does it take to be an EMT. And people are often making sacrifices in terms of their personal and professional lives otherwise. So we have been working with the CDC and hope to implement a pilot project later this year to incentivize more people to pursue training as an EMT. And Mr. Garrison showed you the breakdown of how we intend to incentivize people so that the bulk of the incentive comes at the conclusion of them passing the National Registry test, which makes them eligible to participate in Maryland. We hope to have that up and running in the next several months. And with that, I'll stop and I'll be happy to try to answer any questions. Thank you very much.
Thank you. Are there questions from the subcommittee? We'll start with the Vice Chair of the committee, Senator Rosapel.
Thank you, Madam Chair. I want to go back to the beginning. You were talking about the emergency powers allowed somebody to do something. You went pretty fast. So exactly who was empowered to do stuff they couldn't do before with you under the emergency?
So basically, if I can paraphrase this appropriately, the executive order that affected MEMS specifically suspended the provisions of the education article that is the EMS statute for the state and the COMAR regulations that pertain to the EMS system. And so we issued under the stipulation for, so it authorized the chairman of the EMS board, Clay Stamp from Talbot County, and me in collaboration to issue public notices that enabled us to suspend any regulatory impediment to augmenting the workforce.
Right. I got the big picture. My question is who to do what?
Who did what? So
who was allowed to do things they couldn't do before?
Well, so EMTs and paramedics to be vaccinators.
Okay. Before EMTs and paramedics could not do vaccinations?
That's correct. They could vaccinate public safety personnel, but they couldn't vaccinate the public.
That was the issue. Okay. So is it your view that was successful?
Oh, yeah, it's wildly successful.
Mhm.
So is it going to be continued or is it going to go back to the old way?
Well, that I mentioned that we were successful in getting legislation passed last year that allowed paramedics to vaccinate members of the public for COVID-19 and influenza through January 2023, there is a current House Bill 286 pending that would extend that sunset. So we've managed to do some of that. We recruited people from outside the state, made provisional people. We've managed to promulgate regulations that enable them to become permanent people. We changed the requirement for ambulance drivers of commercial ambulances transporting basic life support patients, so super low acuity people. We've changed the regulation. That was successful. We've changed the regulation to make that permanent. And all there were 9 of these things. The one that we took on that doesn't have a follow through yet are the idea of nurse and respiratory care externs. We recruited more than 1,500 nursing students and respiratory therapy students into the healthcare workforce. But that was tangential to some of the other work that we were doing. And they all expire when the state of emergency expires. And it really becomes the Board of Nursing and Board of Physicians bailiwick to pick them up, if you will, and make that a more permanent fixture.
And what kind of work did they do during the emergency?
So I'll describe the nurse externs first. We worked with all the schools of nursing in the state to categorize nursing students into one of 3 categories. There were nurse externs 1, 2, and 3. Ones were students who had the least amount of education under their belt, and 3s were essentially graduate nurses. And they functioned in hospitals and in places like testing sites and vaccination clinics, right. Commensurate with their knowledge, skills, and abilities based on what the nursing schools validated them to be.
So for me, for common sense, like, what did they do?
Well, so if I was a nurse extern too, I might work with a nurse in a hospital, and that nurse might typically be able to take care of 4 patients on a medical surgical floor in the hospital. And working with a nurse extern, we enabled him or her to be able to take care of 6 patients. So basically, they were nurse helpers, if you will.
Nurse helpers. So, that's my question. And what about the EMTs? Did that get extended too?
Which part of the EMTs?
I thought you had emergency authorization for the EMTs to do vaccinations.
That's like I explained. So a new law passed last year that enabled the paramedics to be vaccinators through 2023,
right?
Up till 2023,
right?
And the current House Bill 286 proposes to extend that through 2026.
Well, what about the EMTs?
EMTs were not included in the legislation last year. They were removed in the process. So paramedics can be vaccinators.
I got it. That's my question. So why are we extending for the EMTs? That's my question.
It was the will of the legislator.
But you proposed that. You wanted it to be extended?
Yes, we would like EMTs and paramedics to be vaccinated.
Well, that's what I'm trying to learn.
Yes, I'm sorry.
So
I'm sorry, my camera's over here and you're over here. I apologize.
I'm on your side. I'm trying to help you. So
for the current House bill, we are really trying to bite off chunks that we could bite off. We're really interested, first and foremost, about getting the sunset extended so that it doesn't expire in the middle of the pandemic. If we could do more at the same time, that would be awesome.
I get it. So would you do this for me? Would you send us on a piece of paper the number of people in your whole world whose legal authority to help people was expanded during the emergency? How many people and what they did, and where you are in the process of trying to making those permanent, just so we have a summary of this on paper of numbers, roles. Could you do that for us?
Absolutely.
That'd be great. Thank you. Thank you, Madam Chair.
Thank you.
Thank you. Thank you. All right, we'll turn to Senator Eckert.
Thank you very much. Yes, and I would say I'd be interested in that too, so that we know what we need to be doing and supporting through the Board of Nursing, because if you were able to bring in and recruit additional workforce, that's significant. And my sense is we've got to figure out how we credential and give people credit for what they were doing through this experience. I want to step back and say thank you so much to you and your team. You know, we know MIMS has been a world-class emergency response system, and you do such great work. And I appreciate how you all mobilized through this pandemic. It's just been remarkable.
Thank you.
question has to do with behavioral health. I see brain disease as brain disease, and I'm trying to figure out how we address the needs of behavioral health, because I'm sure some of the folks that wind up that you even may see may have a life-threatening crisis, either by virtue of acting out or acting in suicide or violence. And that's a major issue. So my question first was, and I'm going to give you a whole series of them, and if we need to take it offline, that's fine, we can do that. First of all, what behavioral health competencies are built into the existing system? As the state works through a crisis response and diversion system, how will you all interface with that? Because, in the rural areas, many times the first people on the scene may be the EMTs or the police. Second part is, with police reform, there's a real desire in our local jurisdictions to, when there is an emergency, to have somebody on site to make the determination whether to go to a police car or to an ambulance, recognizing that with any, I'm a psych nurse, from a psychiatric emergency perspective, I would want medical clearance. But if we could find an alternate route of transport besides putting somebody in handcuffs and shackles and that whole 9 yards, and then beginning that process of what I call getting people into another system, criminalizing mental illness, that's what I'm trying to prevent. That question, so how we think about that, because that's transport, it's reimbursement, and folks are working on that. The other question would be, if we did have an element of behavioral health embedded in your system, would clinicians on the front line be able to access mental health advance directives? So that if somebody who has a severe and persistent mental illness had a plan of care through an advance directive, and somebody could pull that up in an emergency wherever and know what medications have worked in the past, is that something that would work? And I'm just throwing that out to you because I have approached behavioral health. I do have a bill relative to that and getting the technology, but I think your expertise with MIMS is probably the best in helping determine how that system develops and interfaces with you all.
Well, thank you. I'm sure it's a long discussion. I'll try just to touch on a couple of those things. We are really quite interested in identifying alternatives to take patients to that don't include burdening the emergency department for appropriate patients. Right. In a couple of jurisdictions, work has begun in that regard. It is, as you alluded to, not limited, but disincentivized, I suppose, by the payer system, which requires patients to be taken to the hospital in order for the EMS system to be compensated. So that's a topic worth exploring further.
Okay.
But in the jurisdictions where there's a called a collaborative spirit, I think where there's an interest in where our resources are evolving, the EMS system is more than anxious to be part of those solutions to get patients to places other than the emergency room when they go there. You mentioned that there's oftentimes a collaboration of law enforcement and EMS at the scene. I'll call them in crisis situations, and everybody's aware of cases throughout the United States where that collaboration hasn't gone particularly well. We want to be ahead of that curve. We have initiated a crisis collaboration work group. It involves law enforcement and EMS folks and attorneys and mental health people to try to come up with some guidance that we can provide jurisdictions throughout the state and how to determine at any given moment who's in charge, who's got the ball, and how everybody else supports everybody else in the scene, recognizing that these are situations that evolve rapidly, and the need to transition from it being a medical issue to a law enforcement issue and back and forth is very fluid. And we want our people in the field to have the right background, the right preparation for those circumstances. And I think that we'll be out in front if we can do that. So that group has actually stood up, and we hope to have something to provide later this calendar year. It is an issue. We did a survey of hospital emergency departments for a 10-day block of time in November. Behavioral health people represent about 26% at any given snapshot of people who are boarding in hospital emergency departments. In other words, their emergency department care is done and there's no place for them to go. But they represent a disproportionate majority of the actual time boarding patients spend in the emergency department. So it's a real issue worth exploration.
And could you access the mental health advanced directive?
We'd have to figure out a way to do. The short answer to that is yes. Technology is awesome. We just have to figure out how to do it.
Yeah. Dr. Jones said they thought they could work on it through behavioral health. So I just wanted to put that out there in case you see a piece of legislation moving along. But thank you so much. Thank you, Madam Chair, for letting me ask these questions, and I will follow up with you. Thank you.
Absolutely. Thank you, Senator. We'll move to Senator Young.
Okay, thank you. I don't want to just throw a number at you, but are you aware of Senate Bill 515, which I put in this year?
That has to do with Park Service Associates becoming emergency medical responders.
Yes.
Yeah. I have. I don't want to get too far ahead of myself or you. I'm aware of it. I don't think it's. I'd be happy to talk to you offline. I think that situation is resolvable without the necessity of a bill or legislation. I think on the part of its advocates, there might be a misunderstanding that I think we can just resolve simply and easily. I understand the principle. I think that we want folks working in our state parks to be emergency medical responders or beyond, and we want to be able to facilitate, and they used to be. And we want to be able to facilitate their access to education and training and credentialing.
Yeah, if it can be done without legislation, that's great. But there are about 200 people there who have the training. But I think park rangers aren't allowed this designation, and they've been thrown under that group when they're not park rangers.
Yeah, I think there was a transition some number of years ago when park rangers sort of followed this law enforcement path to take get a different credential, and it's the Park Service Associate people. So they're not law enforcement officers, but they fall in a limbo land. Yeah, we can take care of them.
Okay, that's great. I was Deputy Secretary at Natural Resources when we made that change, and I know these employees weren't meant to be looked at that way, but that's great. I can talk to you later or whatever, and if we can resolve it without legislation, fantastic. Thank you.
Great. You're welcome. Thanks.
Thank you both. I see Senator Rosapep. That's a new hand raise, right?
It is a new hand raise. It's the same hand, but for a new time.
Fair enough.
I wanted to come back to the emergency room wait time issue and get Ted's take on that. I presume it's something you're very familiar with.
I'm very familiar with it. And my background is emergency medicine, so I'm all about that. For clarification, the information that Mr. Garrison was showing wasn't just the time somebody spends in the waiting room waiting for a clinician, a doctor, or a nurse practitioner, or whomever to see the patient. It represented the total duration of time in the emergency department. So it encompasses from the time the patient is acknowledged to having arrived until the time they leave the emergency department. And Maryland is an outlier in that regard, but it's not just the time waiting to get seen for your chest pain or whatever. It's a very, I don't want to overly dramatize the situation, but it becomes very complex. So part of it is who comes to the emergency department for care. Are people there unnecessarily? Part of it has to do with what happens on the back end. At any given moment in Maryland, somewhere between 20 and 25% of the patients in the emergency department are waiting for something else to happen for them. They are people who are admitted to the hospital and have no bed to go to. They are behavioral health people who need to be placed there's no place to place them. And so takes space, and those people are included in that characterization of emergency department wait time. I think Senator Young asked a question about, or talked about his chest pain and going to the emergency department, taken care of promptly. We do keep track of some time-sensitive conditions and how rapidly they are taken care of. So we know when EMS takes patients to the hospital. I can tell you, for example, how long it takes at each hospital in the state, how long it takes the EMS personnel to transition care of the patient from themselves to hospital emergency department staff. And we share that information with hospitals frequently in hopes that they will rise to the occasion. But we know, for example, for people who have had a stroke, how long it takes from the time they arrive in the emergency department until they get thrombolytic therapy, a medication, or endovascular care. And we can tell you, we know what it is at each of the stroke centers and how it compares, and is it worth driving further to get to a place further away to get different sorts of care. We know for people who've had a heart attack, how long it takes to get either thrombolytic medication or be in the cardiac catheterization lab, and similar stuff for trauma. And so for those time-sensitive conditions, we know how Maryland does. And by the way, Maryland does very well. But for the totality of the emergency department experience, Maryland, as Mr. Garrison showed you, we are an outlier and people spend way too long in the emergency department. Then your perspective on why that is, in many cases, seems to have to do with who you are and what expertise you bring to the table.
Okay, two things. One is, I didn't know this before, but 50% variation from the national number, and the fact that there's not wide dispersion among Maryland hospitals. Obviously, Hopkins, Bayview, I guess, is at the top, but the Maryland hospitals have more in common than they have differences, and they have more differences with everybody else. So there's something big going on here that must relate to financial incentives, regulations, culture, something. Has anybody ever analyzed that?
Yes, there have been legislative reports done in the past that talked about ED wait time or ED length of stay and crowding, and we'd be happy to share that report with you. The most recent one, I think, was done 3 years ago, perhaps.
Did it compare us with other states? What I'm getting is comparing us with other states as to why it's so much longer here than in other states. What are they doing differently than we're doing?
Well, I don't want to talk out of turn. I want to tell you stuff I don't really know. I think there are a lot of incentives. So part of the challenge is that we have, world according to TED.
Yeah, please. That's what I'm asking you. I'm asking you.
We have right-sized the healthcare system in a way that makes it so that when people are ready for the next phase of care, they're waiting a turn. And so they end up staying in the emergency department longer than other hospitals in other states. We have also structured the financial considerations for how care gets paid for in a way that encourages hospitals and the clinicians working in those places to keep people longer in the emergency department to get care instead of admitting them to the hospital, which is perceived as to be a more expensive thing. I'll give you an example. When I was a young,
you don't need to give an example. That's what I kind of guessed. It was the waiver. It's the way we regulate stuff. It's the financial incentives. So I don't want to drag out this issue in this hearing, Madam Chair, but I would like to get, and I think all of us would like to get, the actual analyses that compare, because there are two problems with long emergency room wait times. One is, well, there are three problems. One is the incredible misuse of services and incredible waste of resources. And that's obviously a big problem. It's very intense, high expense, number one. Number two, people may not get the care they need. But three is a lot of people don't go to an emergency room because they realize it's going to take half their life. And that discourages people to come when they should come. I mean, there are a lot of problems with that. And so I personally would like to really get whatever comparisons are explaining the differences, try to understand it for us to come back and take a look at. So I appreciate that very, very much, Madam Chair. Thank you.
No, thank you, Senator. Thank you, Dr. Delbridge. I think a part of the issue too is we've spent a lot of time talking about the why, but the next step is talking about how to mitigate it, what we can do to address it. And so I think your step, Senator Rosa Pepp, is a first step in that process. We've been in this state for some time about non-emergent use of emergency rooms,
Yeah.
access to primary and preventive care. We've talked about, trying to make sure that we have the appropriate venue, the most appropriate setting for people to receive care, but it sounds like we still have some work to do.
Amen.
So,
thank you.
Thank you all. All right. I don't see any additional hands raised for Dr. Delbridge or his team. So thank you for your presentation and for your responses. Thank you to the analysts. That will conclude the hearing on MIMS. We will now turn to the Maryland Department of Health professional boards and commissions. We have our analyst Morgan Smith presenting. Good still morning, Ms. Smith.
Thank you, Madam Chair. Let me just share my screen. Can you all see that? Okay, so for the health professional boards and commissions, their budget increased by $5.1 million in fiscal 23. That's about 11.2% to $50.9 million. And you can see here that the majority of this is special funds, which are primarily used for the administrative purposes of the boards, as well as paying contractual workers and providing benefits. And the mass majority of this is actually spent on the Medical Cannabis Commission. So in Exhibit 1 here, you can see an overview of agency spending. And about 70% of this allowance is dedicated to regular and contractual full-time equivalent staff members. And the next biggest chunk is the contractual expenditures. It's 24%. And as I said before, the majority of this is the Maryland Medical Cannabis Commission. In the where goes chart, I just want to talk about the proposed budget change. And so, as I briefly said before, most of this is the Medical Cannabis Commission. I want to point out a few things before that. The Board of Physicians, the biggest change here was $567,000 for contractual services. And that's broken up among various contractual services. So I just left it as a bulk number. And then here is where I really want to get into the nitty gritty. So the Maryland Medical Cannabis Commission, one of the biggest changes here is $1.9 million for additional contractual services. And this is primarily due to just a general growth in this board. I believe they were established in 2019, so they're still in the process of growing, adding employees, getting things like identification card printers and things like that. So you'll see here that most of that 1.9 million is for the licensure database, analyses done in different labs and things like that. Additional growth can be attributed to payroll expenses for the full-time equivalent employees, and then things like scientific lab equipment and furniture and rents. Moving on to personnel. So in fiscal 23, the health professional boards and commissions saw a net increase of 3 positions. And what that looks like in practice is actually 2 positions being transferred out to other parts of the Department of Health and 5 positions transferred into the boards. One of those was for the Board of Physicians, 3 were for Board of Nursing, and 1 was for a various other board. And you'll see that in the contractual full-time equivalent employees, it grew by 10.1 positions between the fiscal 22 working and the fiscal 23 allowance. Of those, 8 of them are for the Maryland Medical Cannabis Commission, primarily for administrative purposes like processing licenses. And then the other 2, one was for the Board of Dental Examiners and the other was the Board of Physicians Quality Assurance. There are a couple observations that I want to just bring to your attention. So Exhibit 3 shows the number of boards who have missed their managing for results goals between fiscal 2017 and fiscal 2021. The boards are expected to meet certain goals like issuing 95% of their initial licenses within 10 days of receipt of the last qualifying document. And they're also expected to complete complaint investigations to 100% within 180 days. That does vary a little bit between the Board of Physicians, the Board of Nursing. Their expectations are a little different, and I outlined them above. And the other note is that the Medical Cannabis Commission is measured in a different way, so they're excluded from this exhibit. But as you can see, many of the boards did meet the goals. Of 21 measured, 14 met initial licensing goals, and 16 successfully met their renewal goals in each of the last 5 fiscal years. In Exhibit 4, this exhibit is a little confusing, so I'm going to break it down. So Exhibit 4 shows aggregate data from the last 5 fiscal years. So there are instances where a board may have succeeded in meeting their goals for 4 years, and then in 1 year they didn't. So they didn't meet the threshold to get an X on this chart. So I just want to point that out, and I'll point out a couple examples while I talk. So the chart was made to describe whether the individual board was able to hit their percentage goal of licenses issued, renewed, or investigations completed in the last 5 fiscal years. So for instance, to the thing I just mentioned, the Board of Physical Therapy, it looks like they didn't meet their investigation goals, but in reality, they met them very well. I believe 100% for every year except for 1 year. So they didn't meet the threshold to get an X, but they are succeeding in their goals. I do note that there are several boards that it looks like they met no goals, but they were operating within the 80th and 90th percentiles within the 5-year span. But they just weren't able to consistently meet them in a way that had them meet the threshold. There is one board where this does not apply to, and that is a place of concern for me. The Board of Dental Examiners has consistently missed their goals over the last 5 fiscal years. In fiscal 21 alone, they only investigated 37% of their complaints. They had 3% of their issued licenses, their renewals issued, and 13% of initial licenses were issued. So they're far below the percentage that we would like them to be at. So given this consecutive failure, we've asked the Department of Health to submit a report detailing the Board of Dental Examiners' difficulty in reaching these goals and how we might be able to get them up to par with a lot of the other boards and how they are operating. As far as other pieces of concern, I would like to touch briefly on the cybersecurity incident. So we don't have a lot of details on this. It's still, information is still coming out as the investigation goes on. But there have been several reports, namely in the Health and Government Operations hearing on January 13th, of difficulties of boards being able to maintain a backlog or get in front of the backlog of licensing and investigations, because a lot of these boards had to move to paper applications. And in particular, in the HGO hearing, it was reported that the Board of Nursing had volunteers helping process some of these applications. So because of this, this information that came out during the HGO hearing, we've asked the department to submit a report detailing the cybersecurity incident and talk about how the health professional boards and commissions might be impacted, specifically in their licensing, renewals, and investigations, to see how they plan to get them back up to par, how we will help them reach MFR goals in the recovery after this cybersecurity incident. And then something else I'd like to touch on briefly is the anticipated and actual expenditures of this licensing and regulatory management system program, which is the major IT development project by the Department of Health, specifically for the boards. So between fiscal 21 and 2015, these are the actual and estimated amounts of the project. And previously, the funding for this came out of the Board of Physicians, but it kind of stalled a little bit. So we saw the administration take on this project. And when the administration took on this project, it actually moved to a different area of MDH. So it's actually under Andrew's purview. But I wanted to comment on it here because in the budget books in 2022, the projected cost of the project ending in 2014 was only about $2 million. And in the budget book for 2023, the project is expected to end 1 year later in 2015, but cost $10 million. So that's a pretty big jump. And we've asked the department to comment on this increase in total cost. It wasn't clear to me why the cost had jumped that high. So we're hoping that between MDH and DoIT, they can submit a joint report that would detail the cost of the projects and hopefully talk about which boards are anticipated to reap the benefits of this new system, considering it's pretty pricey. I want to point out, there are two appendices that I won't necessarily walk through. One of them outlines audit findings. They are repeat audit findings from a previous audit that I believe was talked about in the analysis last year. It came out in early 2021. And there are going to be 3 recommendations that are based on this audit. So I'll talk about that briefly in a minute. And then there is another appendice that outlines the current status of the IT program, and it'll show you the breakdown of costs per year. So that'll be helpful when you're thinking about this exhibit. So I'm just going to briefly walk through the recommended actions that I did not already talk about. So recommended action 1 is to withhold funding for the Board of Professional Counselors and Therapists and the Board of Pharmacists. And this is primarily due to those repeat audit findings. So we want to make sure that the Board of Counselors and Therapists and the Board of Pharmacy, they don't repeat the findings again. So we're asking them to comment on how they plan to remedy these findings moving forward. And recommended action 3 also talking about the audit findings. So there was, I believe it was repeat finding 3, where 19 of the health occupations boards did not have adequate control over the collections and deposits. So we've asked the board as a whole to comment on this repeat finding, talk about how they're going to identify steps to remedy it and resolve the repeat finding for next year. And recommended action 5, also about the audit findings. And this would restrict funds for the Board of Nursing, just due to concern over the repeat audit findings. They had 2, it was finding 1 and finding 5. So we're hoping that they can also comment on the steps that they're taking to try to remedy the findings. And I will scroll down to the audit, sorry for the scrolling, so that you can see what the findings are on your screen. So you can see findings 1, 2, 3, and 5 are bolded because they're repeat, but finding 2 is actually in the Office of Healthcare Quality Analysis. So you can ignore that one, but findings 1, 3, and 5 are the ones that we're concerned about, and we've asked for the Department of Health to comment on. And I'm happy to take any questions that you might have at this time.
Okay, there are questions. I see Senator Eckert.
Senator, you're on mute.
Ma'am, you're muted, Senator.
I am. That maybe is a good thing. I have a lot to say. Morgan, thank you very much. And it occurred to me, I've been on a budget committee, as have my colleagues, for a long time. And I think in the past we have had in the analysis, or maybe there's some kind of a document somewhere that gives us each board and their income by virtue of licensure, if they're a self-funded board or if they're not, and then what other funding do they receive from other sources? What I'm trying to do is to get a handle on who's self-funded, who is not, and then who has authority over that, and then what are the common functions? Because this is coming up in a bill, as you all know. What are those common functions that, and I think we had budget language or a bill to look at that computer system, thinking that would help some of those administrative functions, but how we can help those, how we help the boards, but what is it that needs to be combined so that if a board doesn't have the funds that they need, where do they go to get additional revenue? What are the implications of that? Because I'm concerned. Our boards, our health boards assure the public safety. Entry into practice primarily. The professional associations are responsible for then the professional parameters, but our practice acts drive safe practice. And when I see a lot of high investigations that aren't being handled, when I see that licenses are not being renewed in a timely way, and then, you know, we want to know what's that all about, what is needed, what isn't needed, and how do we get those boards and commissions functional enough to be able to provide high quality services that are needed for our professionals, particularly in light of the pandemic, because they're all being asked to credential people, get people into the pipeline, but it's a detriment to the professional potential workforce if they can't navigate through the boards and commissions in a very responsive way. And I'd like to know what we could do to be able to support that, but I think we need the data to get some information on knowing how to do that.
I think that's a good point, Senator. And I'm more than happy to provide that information offline because I don't have it in front of me.
Right.
And the department might be able to comment on that right now, and then I can provide it to you later.
Great. Thank you, Madam Chair.
Sure. Thank you, Senator. We'll turn to Senator Young for a question.
Thank you. Well, Senator Eckert very well covered a whole lot of what I would ask about, so I don't need to.
Sorry.
But no, good. The Cannabis Board, it sounded like there's a pretty big expansion in employees going there. Is the cannabis, is medical marijuana, the cannabis growing that fast, or are there problems that they need that many more employees? Or?
I don't believe that there are problems. I do think that they are growing pretty quickly, and just finally getting their footing under them, realizing the things that they need, whether that's personnel, labs, IT projects. You can see that, I think in the Where It Goes chart, I can show it to you again if you need it. Some of their funding is just for things like furniture, and rent, like very basic things. So I think most of that funding is just getting established across the board.
Okay, thanks.
You're welcome.
Thank you very much. Any additional questions for the analyst? Okay, seeing none, we will hear from the Honorable Dennis Schrader, Secretary of the Maryland Department of Health. If I wait 1 minute, I'd be saying good afternoon, Mr. Secretary, but it's good to see you again. I think it's still good morning.
Yes, good morning, Madam President Pro Tem, and thank you for having us today. I'm joined by our CFO again, Emily Brandenburg, Kim Link, who is our board coordinator, and Webster Yee, our Assistant Secretary. I did want to ask, and I apologize because it may not be possible. We wanted to allow Lorraine Smith, who's the Executive Director of the Board of Psychology Examiners, who apparently has been designated by the smaller boards to speak on behalf of the budget. She may have made a request to come in, and she did. Unfortunately, we didn't have her on our list originally, so I apologize for that. and she may have tried to get in and didn't have the 2-day rule. So I just wanted, if she's not able to get in, we'll get her written testimony and submit that after, but I did want to acknowledge her interest in speaking.
Sure. Philip and Will, can you all see if she's in the waiting room?
No, we don't. I haven't seen her in the waiting room. There's nobody in the waiting room right now.
Okay.
Well,
Mr. Secretary, could you
we'll
say her name again if you want to reach out to her? We're
Yeah.
happy to have her join.
Yeah, her name is Lorraine Smith. She's the executive director for the Board of Psychology Examiners, and they've designated, the smaller boards have designated her to speak on budget matters. So we'll make sure, so I do apologize for us not having had that organized ahead of time. I am going to ask Assistant Secretary Yee to answer the questions from the analysts, and I do appreciate the analysts' work on this. I also want to acknowledge that we have representatives from the nursing board who signed up ahead of time, as well as the physicians board, and they are on the line. So I'm going to turn it over to Assistant Secretary Yee to give the answers to the questions that were posed by the analysts.
Very good.
Thank you, Mr. Secretary. Madam President Pro Tem, members of the committee, Webster Yee, Assistant Secretary of the Maryland Department of Health. We again thank the DLS analyst for her very insightful analysis. We have submitted written testimony, which should be in your packets. And without going fully into depth in all of them in exhaustive detail, with respect to the dental board, we certainly have a shared interest in working with our health occupation board to see how the Maryland Department of Health can help improve customer service and operational processes. So it's a continuing dialogue, and we certainly concur with the analyst's recommendation. With respect to the request for a report on the cybersecurity incident, we respectfully disagree with this recommendation. We provide weekly network incident reports via letter to every member of the General Assembly. In our written testimony, we provided last Friday's report. There will be a new update for this week, and all of our information is also posted on our website about the cybersecurity incident. With respect to the Board of Nursing, and again, as the Secretary said, we have Karen Evans, the Executive Director of the Board of Nursing, available to answer additional questions and specificity. The board posted on January 27th, we were able to work with them collaboratively that they are now able to process renewal applications and submit new online applications, and they will process applications in the order in which they were received. Since the restoration of these licensing systems on January 27th, as of a couple of days ago, the Board of Nursing has processed 9,400 online applications. A relative small minority of these applications, about 6%, are still going through a background check. But as of a day or two ago, 8,774 applicants have had fully completed applications processed by the Board of Nursing. At this time, the primary pending licenses out there are paper applications, applications which require a background check, and license applications which require verification of education requirements. We are working with them both with computer and network equipment and staffing assistance to help them get through this incident. And again, attached to our testimony is a more in-depth letter of what we have worked with the Board of Nursing on. With respect to the narrative about the Health Occupation Board's licensing and regulatory management system process, we again respectfully disagree with the recommendation. If the committee were to look at the governor's budget in Appendix N as in November, on page N32, the details for the MIDTP, Major Information Technology Development Project for the Health Occupations Technology, the budget is laid out in detail. And we are of the firm opinion that the Do-It one-stop licensing system, which the Cannabis Commission is on, which I believe some of the labor boards are on, is probably the best and most viable alternative to the existing legacy licensing systems at the health occupation boards. And both Do-It and the Maryland Department of Health have communicated to all of the health occupation boards that we hope that they would take advantage of this system at the state's expense. And we're happy to take any questions.
We turn it back to you, Madam President Pro Tem, for questions.
Thank you very much. Are there questions? Senator Eckert.
Of course, there are questions. Thank you very much, Madam Chair. Mr. Secretary and team, thank you so much. As always, you all are always on, seems to me, always on the job 24/7. If it's not one thing, it's another, pandemic or cyber attack, or who knows what we're going to get next. Let's hope it quiets down for a little bit. But I do have a question. On this new computer system, how long is that going to take to get it up and running, and how much? Because my concern is that, I think my perspective with a number of the boards, they want to be more responsive to their constituencies. And I just want to make sure they have enough staff and they have enough resources to be able to do that. And you know, getting a computer system up and running takes time and money. And I don't know if there's a short-term fix for a long-term solution. How do we do that to make sure the boards can be responsive now, but move into this new system? I mean, are we going to be another 5 years down the road before we get a system up and running and another 100 million?
Well, let me go back to our experience with the Cannabis Commission. About 3 years ago, the Cannabis Commission was in deep trouble. Their system was failing. They asked us for help. We stepped in, working with Do-It, and within about 6 to 8 months, they were up and running. The one-stop portal is already built and designed. It just needs to be tailored to the individual function at hand, and the Cannabis Commission did not have any problem during the network incident. They've been up and running, and as you heard earlier, their volumes have been growing. So we were very fortunate there. We have also offered, and I think there may be a bill in front of the legislature this session, where we have offered to pay for all the infrastructure costs to support the board out of general funds. We believe the department has that obligation to do it. We don't currently do it, but that would include things like HR, infrastructure for IT, among others. And we really want to, and we believe by having us provide those infrastructure dollars, then the boards can use their feed money to deal with the process of managing the licensing process, which we don't, obviously can't and don't want to be involved in. But what we believe we can do is through general funds, and that'll take the pressure off the fees charged by the boards.
So when, like, for instance, take the Board of Nursing, because I know more about that than anything else, but how long would it take for that system to be operational?
I'd say less than a year. And we've got money in the major IT budget that the governor's put in. So what we're working through is what's called, and I hate acronyms, but it's the Major IT Development Program that Do-It sponsors. And we work with them, we put projects in. We've been working with the Board of Nursing on their project, and that money is proposed in this budget. Once that's done, I believe this thing can be done in less than a year and done very quickly.
Okay, that sounds good. Now, and the other question I had, because I know there is a bill out there, but the bill that I saw would essentially have the boards answering directly to the secretary who would appoint their executive director and some of those things. Is that all a part of your thinking?
Those are proposed in the bill. The big thing would be having the boards continue to be independent in their licensing and complaint processes, but the secretary, right now, I'm not responsible performance. So I think we've made the point that 25% of our complaints that come through our customer service desk are about the boards. And we work closely with the boards. Kim Link is a coordinator, but we have no direct authority. All I want to be able to do is to write their performance evaluations. And this way we have a relationship in that regard. But they would still be independent because most of the board chairs, and we've had 2 meetings recently with the board chairs to talk about this, they're working full time. They don't have the time to put into managing the boards, and we're willing to provide that and pay for it out of general funds if we're allowed to.
So that would mean that, well, I just need to get it clear. I have grave concern that the boards about authority and control, because I think the boards need to be independent, and I think they don't need to be subject to, they need to be neutral. I just put it that way, and I think that's why they're set up the way they are, but there are needs, and there does have to be some common other way of doing that. So maybe I can have a conversation offline with you about that, just to make clear that the professional boards are able to elect their own people and hire their own staff. But then how does that work with the line of being able to access other resources, i.e. technology or streamline functions, so that they can be free to do what's within the practice parameters?
Yeah, I'd be delighted to talk offline, because we're we want to support the boards. They deserve the support.
Yes.
And we need to find a way to help them because some of these things are complicated, and I think there's a pathway to that solution.
Right. And I'm sure you've talked with the individual heads of all those boards to have some kind of brainstorming on what they see would be helpful to be able to get that worked out, right?
We have been working with the Board of Nursing. We would love to have the conversation with the other boards. We've been talking directly to the board chairs, because technically, legally, the board chairs are the ones that are accountable.
Right. Thank you. That's helpful. And I would just stress, I want to make sure our boards have what they need to be just top of the line. You know me, I want everybody to be top of the line and number one across our country. And we have a number of bills before that impact entry into practice. So, when we're trying to expedite entry into practice and recruit newbies, but yet maintain those highest quality standards, I just want to make sure they have what they need to be able to make that a reality quickly. Thank you.
Thank you, Senator, for those questions. I actually, Mr. Secretary, I joined, look, my lights went out. Okay. And sitting on, we're saving power here. I actually joined Senator Eckert in, so first of all, appreciating your offer, if I heard you correctly, to help the boards with some of the expenses related to the advancements in technology that can ease or expedite the reporting. And also, it sounds like there's another conversation that I wasn't aware of that may change some of the leadership or lines of reporting as it pertains to those boards. I'm very interested also in following up offline with those. I share the senator's concerns about not wanting to lose sort of the independence or autonomy of the board, but I was not aware that you were receiving that large a percentage of your incoming complaints related to that. So somewhere there's got to be a compromise solution that allows them to maintain their independence, but gives you some authority where you're having accountability and responsibility. So
I couldn't agree with you more. And we definitely want to find a mutual pathway. We have been talking to Senator Kagan about a possible bill that's in DLS. So we're working through that. We want to find a compromise here, but it's critical that we get the resources to the boards so that operationally, and what I would prefer to have is just the ability to write the performance appraisal for, not run the thing, but just be able to do the performance appraisals for the executive directors.
Right. But in order to do that, there would need to be some,
Correct. Yeah. We'd have to negotiate something. And
exactly.
There's got to be a way to do this in a collegial way that makes sense.
Well, let's keep talking, and certainly whatever we can do to help streamline processes and make things more functional, we're happy to do that. I don't see any additional hands from the subcommittee. And I don't know, Mr. Secretary, if the other person you were looking for, I don't think they ever arrived. So did you have any closing remarks or anything?
No, I appreciate the time today, Madam President Pro Tem, and what we will do is make sure we get the remarks from Ms. Smith and follow up with you. But otherwise, I would say one other thing, which I think is important, and that's why I think Ms. Smith's voice is important. The boards, there are very large boards and there are very small boards. And for the small boards in particular, the wherewithal, we don't want to be raising fees to the point where somebody who's making $35,000 a year is paying $500 for a license. That doesn't make any sense. So that's why I think the department providing operating money for infrastructure is important, and particularly for the smaller boards who have, much less resources.
Absolutely. And as the Senator Eckert said, as we're in an era of looking for recruitment and retention, things that we can do to ease the burden on those that are providing the services on a day-to-day basis are going to benefit us all in the state moving forward. So thank you for that. Seeing no further questions, we thank the analyst, Ms. Smith. Thank you, Mr. Secretary, and your team. Colleagues, thank you for your time and attention. That concludes our hearings for February 4th, 2022.
Thank you all. Keep up. Thank you, team.
Thanks, Philip.